Welcome to Healthy Frontiers. My name is Dr. Bizzoni, and this show is dedicated to the education of our viewers. Tonight's topic is understanding MRIs, CAT scans, X-ray, and my special guest is Dr. Stephen Winter. Dr. Winter is a fellowship-trained MRI specialist and chief of radiology and director of radiology for Open MRI. There are 14 sites in New York State area. 2 right here in Westchester that he works very much with is in Eastchester and in Yorktown Heights. Dr. Winter is a Dartmouth graduate. He got his MD degree from New York Medical College. He graduated with high honors at the Alpha Omega Alpha Honor Society. He did his residency at New York University Medical Center. He's had much advanced training in chest, abdomen, and pelvic imaging. He's a assistant clinical professor at Cornell Medical Center. He's also a member of the Radiology Society of America, the American College of Radiology, the American Röntgen Array Society. He's been published. He's married, lives here in Westchester. He has 2 children. And I'd like to welcome Dr. Winter to the show. Welcome, Dr. Winter. It's a pleasure to have you here.
Thank you for having me on today.
It's my pleasure. Doc, tonight's show, hopefully we're going to explain to our viewing audience what the difference is between MRIs, CAT scans, and X-ray, why we need them, what it's all about. So why don't we start with what the word MRI or the symbols MRI stand for?
Sure. MRI stands for magnetic resonance imaging. When it first came out, it actually had different initials. It was called NMR, which stand for nuclear magnetic resonance. That got changed fairly quickly when it was learned that the main use of MRI was actually in getting a picture of a patient. And it rapidly became developed as a diagnostic tool and is right there along with CAT scans and mammographies and X-rays and ultrasounds as part of the studies available to clinicians that can help diagnose and diagnose patients' problems. Mm-hmm. And it's become a tremendous diagnostic tool in medicine. In fact, the physicists who developed MRI initially received the Nobel Prize in medicine about 6 or 7 years ago.
Oh, that's tremendous. Mm-hmm. Okay, so it's a tremendous tool for us.
Yeah, okay, very much so.
How do magnetic fields get created on images? Let's talk about that. Let's get into the little physical part of it.
To try to oversimplify this,
yes.
It's very, very highly complex physics properties. But to break it down into a very simple way that you can understand, that the patients can understand. Inside, everything is made up of a proton.
Yes.
And that's where the word nuclear comes from initially, because the nucleus was made up of a proton. And everything really comes down to imaging hydrogen atoms. Okay. And in the body, the hydrogen atoms, without any magnetic field, are moving in completely random directions. Mm-hmm. A good analogy would be if you have a light on in the middle of summer, you see all the gnats flying around randomly around the lights. That's kind of the way protons move inside your body when you're not in a magnetic field. Okay. What was discovered is when there is inside a magnetic field, all the protons will move all together in sync, in direction. And the basis of imaging MRI and magnetic resonance imaging is you hit all the protons so they're moving in sync, mm-hmm. and then you remove that little jolt, yep. And then each different tissue in the body goes back to being kind of random at different rates.
I see.
And the way you get imaging and the way the different tissues look differently on an MRI image is that, say, fat has a different return back to being random than muscle, than water, and everything else. So depending on how it goes back to being random from being in sync is the way MRI gets imaging.
All the different densities of the tissues are going to send back this different message.
Exactly. So the magnetic field is critical because you need to have the magnetic field to get everything moving in sync.
Right.
And the noise that you hear when you have an MRI, and people who've all had MRIs all comment about the noise.
Yes.
And it's not a quiet examination.
Right.
But the noise is the radio frequency pulses that actually generate the protons moving in sync. And
I
not.
see. So that's going to distinguish the ones that aren't and the ones that aren't. Here's where you
Yes.
get the picture that's going to tell you the diagnosis. So hopefully get closer to it.
Right. And every tissue has a slightly different rate that it goes back to being random. So that's how the physics transfers into a picture on a piece of X-ray film.
That's great.
Yeah.
Is it safe to have an MRI, Doc?
It's extremely safe to have an MRI. In a magnetic field, there's no harmful effects on the body in a magnetic field.
Okay.
And there's some rare occasions if patients have had metallic fragments put in their body either by injury or by a medical device. Some of those, and actually very few of those, are something we need to know about. So when a patient gets an MRI, the MRI facility is always going to ask the patient about certain, is there been any history of working with metal? Have you ever had any gunshot wounds or shrapnel injuries? Have you ever had stents put in medically? Have you ever had aneurysm surgery in a pacemaker? And really the two most important ones that we look at for MRI functionally are brain aneurysms. Right. Because historically, when the early brain aneurysm clips were made, even the slightest amount of motion of an aneurysm clip could have very serious effects, of course. So up until recently, nobody who had a brain aneurysm clip could have an MRI. The technology has changed where the brain aneurysm clips are now not
magnetized.
Yeah, exactly.
Yeah, sure.
And they're not attracted by the magnetic field. Right. And even now, patients who have aneurysm clips placed recently, within the last 5 years or so, can also safely have MRIs.
Oh, that's great.
And the same thing now with pacemakers. And pacemakers still is one of the main reasons why a patient cannot have an MRI. Okay. And that has a battery in it, and that's the main issue. It will cause either battery to not work or to malfunction.
How about staples from prior surgeries?
Yeah. Most of the staples are made of titanium that are used now, and titanium is not attracted by a magnetic field to any prominent degree. So with almost no exception, surgical staples are not a problem. Most manufacturers who make any surgical device, whether it's a stent or a staple or a surgical clip or a small metal stent, they recommend that the MRI not be done for 6 weeks, but it's practically it's probably less than that. Okay. And it's a medical decision by the radiologist involved. If there's an emergency and if there's a severe injury, whether a patient has an injury to a tendon or a muscle where they might need surgery, there's always a benefit to there's a risk and a benefit to every decision in medicine. And if the patient has a small staple from a gallbladder surgery or from a surgery somewhere around the body, that's not a significant risk, but you want to make a diagnosis. So it's really a medical decision as to safety.
Yeah. Right. Is it painful at all to have an MRI?
It's not painful at all.
At all.
For the great majority of cases, the patient lays on their back, and tries to lay still, and that's really the examination. Rarely is there anything that has to do with motion or anything else. So the patient just lays back and lies still.
And for my practice, I know sometimes we'll have patients with severe back pain, and they say, well, how could I lay in that tube, Doc? I say, well, you can have an anesthesiologist present, and there are other ways to get the job done. Is that true?
Oh, yeah, that's true. Yeah. When MRI first came out, about 20 years ago or so, they were in these long tubes where the body was fully immersed inside the tube, and it was a very long examination, in some cases over an hour, just to get routine images like a brain or a spine or a knee. And like with everything else, technology has improvements over time, and the tubes have gotten shorter and shorter. And specifically with the facilities that I work with open MRI facilities in which there is no tube at all, and the imaging is completely open along the side. You're laying on a table and there's a scanner above you, but there's no supporting around the side. So there's different options for MRI. There's open MRIs. There's some stand-up MRIs, and there's still the closed MRIs. And what has been found is that the image quality is indistinguishable between all the MRI examinations. All the studies are diagnostic. Our facilities, the slices are the same thickness.
Yes.
The time of the examination is the same, and the types of examinations that we do are the same. And
That's very significant.
Yeah, and it's becomes more accessible to patients
Yeah.
of all different shapes and sizes. Patients who formerly had a claustrophobia and anxiety of going
Right.
into closed spaces now could get imaged without having to use medication a lot of times.
Well, that's
so
great.
that's simple.
And that's very important because I remember a lot of patients would say, closed versus open versus closed, and oftentimes I'd hear, well, you need to go to a closed MRI, but now you're saying everything is on par, so closed or open is going to give you the same diagnostic quality.
Exactly.
Okay. Are there dyes used? Again, that's another question that a lot of patients will ask is, do I have to have a dye injected, doc? And there are times when you need it, there are times when you don't.
Right.
Why don't you just talk about that?
MRI does use a dye. It's a completely different dye that is used for CAT scans.
But not all the time, correct?
Not all the time.
Okay.
Only in selected uses is a dye used for the MRI.
Okay.
The dye that we use in MRI is called gadolinium, which is when you had to take chemistry in high school, you had to learn that periodic table of elements. Well, you only had to learn the ones on the top.
We hate it.
Yeah, gadolinium is one of those ones on the bottom that you never had to learn.
That's
But it's an element that is naturally but it's relatively rare. But it's been found to cause an enhancement under the magnetic field, and it has properties under the magnetic field that cause it to show vascular flow with tissues and other properties that show if a piece of tissue or a vessel has a blood, if there's a blood supply.
Yes.
So. It's used in some cases and not all cases. It's used not uncommonly in brain imaging. It's used in patients who've had previous lumbar spine surgery.
Yes.
Because if a patient's had lumbar spine surgery, you can't differentiate sometimes between the scarring from the surgery and the disc herniation that comes back after the surgery.
Okay.
But the great majority of the tests for spine imaging don't need the dye.
Right.
Most of the extremity imaging does not need dye.
Okay.
And the other reason we use dye a lot is if we're imaging the vessels themselves, and that's called MR angiography.
Okay.
And the routine imaging, if you're imaging a knee or an ankle or a shoulder, that's typically referred to as MRI, magnetic resonance imaging. So the A would stand for arteriography, which has to do with the vessels.
Right, so with the blood. Now, what's the difference between an MRI and a CAT scan? A lot of patients will be said, Mr. Jones, you should have a CAT scan or maybe an MRI. Well, just tell me, why would someone want an MRI versus a CAT scan before we take a look at what an actual MRI of a spine would look like?
Well, CAT scans are really elaborate X-rays. It uses X-rays and electrons and is a measure of density. So you're putting electrons through the body, and essentially what's more photons come out on the opposite side if there's less blocking it.
Right.
For instance, if it hits bone, it's going to be blocked completely. If it hits air, it's going to go completely through. So X-ray and CAT scan has the same properties, in fact, that you're looking at densities of tissues. Okay. MRI, you're not looking at density. You're looking at this rate of how it goes back to randomness from there. So they complement each other with the types of information.
Okay.
You can see bone very well on a CAT scan or an X-ray.
Right.
You actually don't see the bone, the dense part of the bone on the MRI that well, but you see the bone marrow, the fatty bone marrow that's in the center of the bone extremely well.
So for each part of the body, that's the doctor's decision right there. Let's see. We're looking for a certain thing after the diagnostic workup, that would make sense.
And one other advantage of MRI is that you can look at MRIs in any plane of the body. So you could look straight at it, you could look from the side, you could look kind of from above or below as well. CAT scans, you're really limited to looking at it in one direction, and sometimes they can reconstruct it and they can look at it in other planes, but primarily you're looking at it in one direction.
Okay. Great. And, we're going to take a look now in a moment, but most times a patient will have an X-ray, and that X-ray will just show the bony structure, correct? So then we say, okay, well, maybe it's a little spinal disc problem. Is talking for myself from spine area, or but we're talking soft tissue, you want to get an MRI.
Exactly.
So one of the things that is most diagnosed spinally is a herniated disc,
Right.
or a ruptured disc, as the term may be. So why don't we take a look at an MRI right now and see
Sure.
what you see on that and what you can't see on an X-ray, and let's demo that a bit, Doc.
Okay.
Let's go right from the beginning so everybody understands the anatomy of what we're looking at.
All right, this is a side view of your lumbar spine, which is your lower back, and these are each lumbar vertebral bodies, and you have 5 lumbar vertebral bodies, and these are two different ways of looking at the MRI. And we typically don't just take one picture; we take 3, 4, 5, 6 different types of ways of looking at them, and they all add certain different types
angles,
of information.
is that what we're doing there, Doc?
Exactly.
Okay.
So these are the lumbar vertebral bodies, and this is the first lumbar, second, third, fourth, fifth.
These square boxes, for the audience to understand,
Yes.
are the actual bone vertebrae bodies.
Exactly.
Okay.
And again, this is a side view,
Right.
and these little boxes here is actually kind of an idea of where this picture is. It's cutting right through the middle if you're looking from the front view. But this is essentially looking at somebody from the side, and you're seeing between each of the vertebral bodies is a disc, which is which is an irretrievable disc. It has a soft gelatinous center called the nucleus propulsus, and it's surrounded by fibrous tissue. And you can see that the disc in the bone has a very smooth interface. And in this patient who doesn't have any disc disease at all, this is a normal lumbar spine MRI, that you can see very clearly that the junction of the bone and the disc does not cause any compression on this structure. Now, this is the spinal canal. So this white material here is the spinal fluid. So if someone's got a spinal tap and they draw out fluid, they're actually sticking a needle right about here and getting out the fluid.
Correct.
So, one other important structure here is the spinal cord. The spinal cord only goes down to about the mid to lower back. It only goes down to about the first lumbar vertebral bodies. And then all you have is strands of nerves that come down that are called nerve roots that come down. So actually your spinal cord only goes down to about your lower mid-back.
Right.
And then below that are the nerve roots.
So just an extension of that, like a horse's tail, so to speak, right?
Exactly.
Okay.
Exactly,
Okay.
and just some other structures you see here is like these are the bony vertebral bodies. These are remnants. Everyone knows kind of the dinosaurs have those big spine plates on the back of it, and humans have them to a very small degree. And we're seeing this is the belly button. This is the umbilicus here that you're seeing.
Right.
And here's so you're seeing fat tissue here. You're seeing bone marrow, which actually has fat in it.
Okay.
And you're seeing intervertebral discs here on here, and you're seeing spinal cord here and here, and nerve roots coming down.
So then a patient comes into us, Doc, my back hurts, okay? And I have some pain going down my leg, Doc. I have a little numbness in my toes. Maybe there's suspicion that there might be something wrong with one of these little pads in between these vertebrae. That's correct?
Yes, exactly.
Okay, so why don't we take a look and see, we may send that patient for the MRI and see what an MRI would show possibly.
Okay, so this is a patient who has a herniated disc.
Okay.
And it's almost like you're looking at things. It's like one of these things is not like the other. And if you look at the first 3 lumbar vertebral bodies, you can see it looks very similar to the patient we just looked at who had completely normal lumbar spine. So these disc levels are completely normal. This disc here, this is between the 4th and the 5th lumbar vertebral body. It looks different. It's it's darker. Then these 3 are much lighter, which means on this sequence, fluid has white. It looks white.
More hydrated, more water content.
Exactly.
Correct? Okay.
So these, and when a disc is well hydrated, it's soft, it's spongy, it's like a brand new sponge. It has a lot of elasticity. With degeneration, you lose that hydration, and on the MRI, it shows up the difference between this one and this one. This is a healthy intervertebral disc, and this is one that's starting to dry up. You're losing that fluid.
So it gets darker, it gets blacker.
It gets darker.
Okay. Yep.
And also, if you could imagine, it's extending a little bit outside of the line here between the posterior body.
And this is in the canal where all those nerves are, where you can start feeling some pain, correct?
Exactly.
Okay.
And that's what's referred to as a bulge.
Yes.
So you have a degenerated disc and a bulge. And an idea of a disc bulge, the analogy I like to use is if you press down on a hamburger, raw hamburger meat, it kind of spreads out a little bit. And,
Yes.
and that's kind of what a bulge does. But it does press on that on that
So a
sac.
bulging disc at times can cause pain, correct?
Absolutely.
Okay. I mean, just a question that a lot of patients will ask. It's only a bulge, doc. It's not herniated, but that can also cause pain.
Bulges certainly can be symptomatic.
Okay. And then
We're going to come down to this. This is the lowest lumbar disc. This is the fifth lumbar vertebral body, and this is your sacrum. This is the top part of your tailbone. And you're seeing this large structure coming out and going out and compressing the spinal fluid, compressing nerve roots, and actually moving away from the disc. And this is a very large herniated disc, or disc herniation. Some people call them extrusions. But essentially the fibrous material that keeps this soft disc material centrally intact has become ruptured and injured,
Yes.
and the material that normally is central within the disc has escaped from the intervertebral disc and is left and is now compressing the spinal canal,
Yes.
causing compression of the spinal of the sheath of the spinal canal called the dura, and also compressing these nerve roots. You see these line strands coming through there. These are nerve roots being compressed.
And
by
sometimes
this
that
disc
it can heal without surgery, but many times it requires surgery. You have to get that out of there at times. Other times the body is able to resorb. Is that true?
Exactly. When you have a disc herniation, a lot of times the body reacts to it. Not unlike if you get a bruise, you get swelling around it. And the same
Yes.
thing that happens when in the body and in the spine, you'll have a disc herniation, but you'll get swelling around it. You'll get edema, and you'll get the edema itself causes
Pressure and
pressure
pain.
and stuff.
Yeah.
And that's why medications like Aleve and anti-inflammatory medicines help when people have disc herniations.
Right.
Is because you're not. It doesn't treat the disc herniation, but it treats the reaction around it.
Around it, right?
So-
And even some of the newer things coming out with decompression and
Absolutely.
chiropractic, I know sometimes can open up some space, and we have some chance, and we've seen some good results with that.
Absolutely. Because it creates a negative pressure, and some of this material can go back inside.
There you go. Okay, Doc, can we go on to the next picture?
Sure.
We're going to look at one more MRI here, or maybe we have time for a couple. So let's go on to this one. What's this one going to show us?
This is another disc herniation, just another example of one of the larger ones I've seen in my career, where again you're seeing material coming straight out of the intervertebral disc and coming down there, and getting an idea how it's compressing. This, you're seeing things come very smooth here, and then this
Cuts
huge
that whole
thing, it compresses the whole thing.
Yeah.
You want to see a
So you're going to have more chance of having more pain in that one.
Yeah.
Okay. Here we go.
And disc herniations are not limited to the lower back, but are also they happen not uncommonly in the neck as well.
Okay.
And we're dealing with some different anatomy here, so if I could just take a
Sure,
second.
let's start.
Okay. This is the just for reference. This is the top of this. The head would be here. Your torso, your body would be here. This is the back. This is the front. This here would be where your windpipe is, and this is where your neck is. Your thyroid gland would be about here. These are now right here in the cervical spine. So there are 7 cervical discs. The second one is here, third, fourth, fifth, sixth, seventh, and these are the upper thoracic vertebral bodies. And this structure here is your spinal cord. And this goes all the way down to where we saw in the lumbar spine, where it ends in your lower back. So, again, the spinal cord is bathed in fluid,
Right.
which protects it. And there's a membrane that's in front and surrounding it called the dura that runs along the posterior margin of the vertebral bodies. And we have an example here of, again, normal cervical discs.
Right.
These
First
ones
couple all normal.
These ones, and the thoracic discs are also normal. And you
Right.
notice how smooth the interface is between the vertebral body and the intervertebral disc. You don't see any impression at all here
Right.
or up here. And then we get down to this one here, and you can see again the material from the disc coming out of the fibrous sheath and extending and causing really a lot of compression, not only on the fluid. You don't even see fluid at this level. At these levels, you're seeing fluid between the spinal cord and the disc. fluid between the spinal cord and the disc. At this level, you see nothing. The disc herniation is really causing quite a severe degree of compression, and it's compressing the spinal cord in this patient.
Okay, so somehow that patient has to get off there. Otherwise, the patient's going to have a lot of pain. They can have radiating pain. They can have pain in their arms. They can have pain in their neck.
Yeah.
Many different symptoms.
I mean,
Correct?
even the neck, it could even go down to the lower extremities.
Right.
It could affect a lot of things.
Sure. Okay, because this is a lot of control right up in your neck area. I always think of the poor Christopher Reeves when he had a fracture in his neck, affected everything from his neck down below.
And that was at the level where he had his injury.
And that was the same level that we were just looking at.
Similar, very similar.
Okay. What do we have here, Doctor?
Okay, this is we're down in the lower back again, and I wanted to show this because this is an example of some of fractures of the lumbar spine. These are compression fractures.
Right.
These vertebral bodies are of different height. If you look at this vertebral body and this vertebral body, they're much shorter than, say, this vertebral body is.
Yes.
The other thing that's important on this image is that they look different. This vertebral body kind of looks whiter. Again, this is the bone marrow of the spine, and inside bone marrow, the main component of bone marrow is fat.
Right.
And the fat looks white on this MRI image. It's because here's the fat in your back and your subcutaneous
See how white
tissues
it is,
are white.
sure.
And these levels here, it's a little different. These you're losing that fat on this level and on this level. And what this patient has, this is tumor infiltrating the bone marrow. So this is a patient who ended up having a tumor in several of the vertebral bodies.
Right.
And,
So you just never know. When a patient comes in with low back, I mean, to us doctors, it's always a question. Is it just a musculoskeletal problem, or could it be a tumor? And patients always want to know that. So, I mean, this would be an ideal test to differentiate if you suspect clinically.
I mean, this is, of course, not common, but there's several causes for back pain. There could be disc herniations, there could be disc bulges, there could be instability from lack of alignment of the vertebral bodies, and you could have problems with the vertebral bodies. You could have fractures that are related to tumor and that are not related to tumor. You could have osteoporosis and have fractures that are picked up on the MRI. You could have aortic aneurysms. We're seeing part of the aorta here. This is part of the aorta. Patients who have back pain sometimes have a normal spine, but they could have aortic aneurysms, and all these can be picked up on imaging studies.
Great. Hey, Doc, I think that was a wonderful presentation. Very informative, very educational, and
Thank you.
did a great job. So I want to thank
you,
you
Lou.
for being on the show. Look forward to speaking to you again.
Thank you.
And for our viewers, I think it was very informative. Dr. Winter was gracious enough to say if you have any questions, he'd be very happy to answer them for you. So you can email him on his website, and we look forward to seeing you on the next show. So thank you very much.